Um, for ketamine, for psychedelics, for all the drugs that everyone's really excited about right now that are psychedelics or related psychoactive compounds, there's this question of to what extent are the subjective effects that people consciously experience actually necessary or important for their therapeutic effects. So as we mentioned, as I've covered on the podcast before, ketamine is being studied pretty intensively right now because it has these acute antidepressant effects. I know that you've done at least one study where you basically combined ketamine with anesthesia so that people obviously weren't aware of the effects when they took the ketamine. Can you set up that study for us and just describe what the motivation was and what the basic results were?
Sure. So, um, the drug versus the trip, that is one of the most interesting, and compelling, and impactful questions because it really dictates where do we go when we try and develop this and scale it up. And just point to folks like David Olson, Brian Roth, who are developing non-hallucinogenic psychedelic analogs, which is a great empirical test of this question. Drugs that have very similar biochemical effect to classical psychedelics, but don't trigger that the experience. Those studies are underway. They've not been tested in a formal clinical trial for a mental health condition in humans, as far as I know. So we don't know the answer to whether taking the trip out of the drug works. So being an anesthesiologist, I saw a very clear solution, another alternative solution to answering the same question is we have patients with depression all the time coming in for major surgery, hips, knees, hernias, things like that. And we could set up a test. We could basically eliminate the conscious awareness associated really the dissociative effect, the trip, by giving ketamine, the same psychiatric dose that's used in countless studies, while they're under general anesthesia. And to be clear, they're getting a different general anesthetic. It's not a ketamine anesthetic. It's where we started. Propofol, sevoflurane is most of the patients in our study. So we tried to set it up as close as we could to a psychiatric ketamine study. We worked with Laura Hack and Alan Chasbury again, who are both actual psychiatrists, to help us get it right. So what we did is we reached out to patients early, and these details are going to be important later on. Patients don't usually hear from surgeons and anesthesiologists about their mental health. So some of these folks are a little surprised. They're like, why are you asking? A lot of folks didn't want to talk about it at all. But anyway, we reached out early. We told them that, we're interested in studying mental health, and we asked them if they want to be a study of a potential therapeutic option that might treat depression during surgery. That was the setup. We took folks who had moderate to severe depression. On average, it'd been for years. These look a lot like patients who were in other ketamine studies that came before. And we track their symptoms using standard scales. And when they show up on the morning of surgery, we would meet them. They would go in for surgery. They would go off to sleep. And we basically waited until they reached a certain depth of anesthesia. So all of our patients were basically at a equivalent depth that's associated with general anesthesia and no recall. Right. This is again where we started our conversation. And when they're in that state, we gave them ketamine. We were blind. We were just put in a syringe. We didn't know what it was. The patients were obviously unaware of what we were doing because they were under general anesthesia having surgery. And the anesthesiologist in the room also didn't know what we had given them. So it was a standard dose, again, a single dose. This was really aimed at if you take away the conscious experience and you just have the drug in your system, you still get some sort of antidepressant effect. We're looking at short outcomes, meaning the 1 to 3 days after the infusion. This is when a lot of the earlier single dose studies of ketamine, how they were set up is the peak effects were at those 1 to 3 days after. So what did we find? The ketamine group, the folks that got ketamine, they got better. They got a lot better. 50% response, 30% remission, meaning half of them cut their symptoms in half or more, and a bunch of them no longer met criteria for major depressive disorder for at least a few days.
Hmm.
This looks a lot like what ketamine does in other studies. Uh, Now, the placebo group also had about 50% response and 30% remission. We could not tell the difference between the groups. Both of them had this enormous treatment effect. And there were patients where, I swear to God, like there were two in particular where I saw them after surgery. And one of them was telling me, like, I could dance. And this was like her fifth surgery for cancer, like, not someone who was like, prone to, exuberant outbursts. Like, she was like just legitimately, like, just happy. Like, it was infectious. There's something that, people like we know about, in healthcare generally, like, sometimes, like, when you find yourself, a patient's attitude rubbing off on you, like, that should tell you something. Like, that's how bright this woman was. And I was thinking, my God, like, this is working. Like, we took the trip out of the drug, and like she's got to be in the ketamine group. Placebo, of course. Another patient where she actually had a pretty rocky postoperative course. But she was, she told us, like, she's so happy to be in this trial. Like, she's able to deal with stress in a way that she wasn't before. She's taking exams from her hospital bed. Anyway, these are the stories that I was accumulating as we're doing the study. So what I want, why I'm telling you that is these were real transformative experiences. Those are those are words that patients use. I didn't suggest that. And it was shocking to me to find out that, like, we're getting these effects in the placebo group.
Hmm.
And that I think made a lot of people uncomfortable. We got a little bit of hate mail for this study. I wouldn't say hate mail, but it's one way to look at this study is that, well, this shows that ketamine doesn't really work because it's no better than placebo. That is not how I look at the study, and to be honest, you can't really interpret it in that way because there was no third group. Where they were awake, for example, and got ketamine.
So how do you interpret it? And then I have basically a question about the study design.
Sure. So the way I interpreted it, we considered a few different possibilities. One, that anesthesia blocked the effect of ketamine, which we think is unlikely because the size of the ketamine effect was so similar to every study we've come before. The other possibility we considered is maybe it's a common factor. Maybe anesthesia itself is an antidepressant. And we talked about that a little bit before. And going back over hundreds and hundreds of patients where mental health is monitored, surgery and anesthesia make depression worse in almost every study. So that seemed very unlikely to explain this. So what we settle on is that it's maybe it's expectation. Maybe, and I hinted at this before, this process of reaching out to patients feel seen, they feel heard in a way that they usually don't in the run up to surgery. These are patients who have issues, major life issues that are dragging them down. And on top of it, they have surgery coming up. And that sets in motion a series of expectations. And that made me really think a lot about psychedelic trials and just how heavily selected patients are there, how excited they are to be in such an interesting study, be an elite group of patients. Like, I am, it's being part of something.
Right. I mean, I remember when I went to grad school, like when you're applying to grad school and then they invite you to the interviews, you feel so good. You're like, I get to go and I get to be part of the group.
Like, I'm on the team. Like,
yeah.
It's that's real. And we did, I was excited to get every single one of these patients because, it's not easy to get folks who are willing to do a study in this surgery.
Yeah.